So there are two parts of the therapy that we are going to talk about. And one of them is assessment and techniques, and the other is exercise, because of course, exercise is our thing. And if you recall from having read the chapter 12 in a Sullivan book, um, in the olden days, I'm going to say, so up until fairly recently, it was recommended that people with pulmonary disorders didn't exercise. Doesn't that drive you nuts? But anyway, um, it was recommended that they take it easy because it's too hard on your respiratory system. Well, we were wrong about that. We were wrong. There were a lot of disorders. It was initially said, well, don't exercise with that. But now we know that you can exercise with a lot of different disorders. And in the textbook, in the 7th edition, I haven't looked at the 6th edition with regard to this, but it has a whole list of recent studies that have been done that show that yes, exercise is a great technique for improving vital capacity in people with chronic lung disorders. Yay. And lots of specific exercises. One specifically is interval training, which we will talk about. And it's good for even people without chronic lung diseases, but we'll talk about how we're going to do it with people with chronic lung diseases. But first, we're going to talk about how we're going to assess and then the different techniques, which we will practice in lab. So the components of pulmonary PT and the techniques used in pulmonary dysfunction to enhance respiratory dysfunction include postural drainage, which means you put someone in a position that's going to promote drainage of secretions from their lungs. Percussion, vibration, and cough facilitation, those are all manual techniques, which we'll practice in lab. Breathing exercises and retraining, we will also practice those. Relaxation techniques, yay. And posture correction, because posture and breathing go hand in hand, just like posture and balance go hand in hand. I always tell people, I probably say this every day in the clinic, is the two things we all need to work on for the rest of our lives are posture and balance. And I guess you could add breathing, but you can't not breathe, or, there's no alternative, but you got to do it right. And then graded exercise and endurance programs, which we'll talk about in the 3rd section of the PowerPoint. So the pulmonary assessment, we're going to look at the patient's general appearance, sputum analysis, it always comes back, breathing pattern, abnormal patterns, breath sounds, and palpation, and we'll talk about each one of those. So the patient appearance, what color is their skin? Are they cyanotic? Are they rosy? Are they, normal? Their normal color. Everybody's skin is a different color, right? So their normal color. If you have a dark-skinned patient, you can assess this by looking inside their mouth, their nail beds, and the soles of the feet. So just because someone has dark skin doesn't mean they're not going to have changes due to respiratory dysfunction. The patient's awareness, are they alert, responsive, or lethargic and disoriented? Or any one of those things, any combination of those things. Suppose you can't be alert and disoriented, but anyway. Facial signs and expressions, dilated pupils, nasal flaring, sweating, hypertrophy of accessory muscles. We're going to look at that. Their posture or preferred positioning. Are they kyphotic, like the person in the graphic here? Are they leaning forward? Do they prefer to have their head up in supine, or to be a lot of people, I hear this all the time for various reasons, not always pulmonary dysfunction, but people say, I can't sleep lying flat. I sit up, I sleep in the recliner. So we're going to learn all that from the patient. Sputum analysis. If people cough stuff up, you should look at it. Nurses have known this for years. Most of us will go, let them cough it up into a Kleenex or something. And then you got to look at it and see, is it clear? Is it yellow, green, blood streaked? Is it viscous, thin, or frothy? How much of it? Like, is it copious amounts or minimal amounts? And if there's an odor, you got an issue. So The types of sputum, if it's yellowish green, cloudy and thick, that's often an indication of a bacterial infection. People with chronic lung disease are more prone to bacterial infections because they have more residual volume in their lungs, and the bacteria might like that if the lower respiratory system gets invaded by bacteria. Rusty or dark colored sputum is usually a sign of pneumonia. Very large amounts of purulent sputum with a foul odor. If you have a foul odor that you're coughing up out of your lungs, that's bad. I'm just saying. And usually there's some type of infection involved. Thick, tenacious mucus can be indicative of asthma or cystic fibrosis. Blood-tinged sputum may result from a chronic cough, but it also might be a sign of tumor or tuberculosis. Hemoptysis, which is basically coughing up bright red frothy sputum, it's usually associated with pulmonary edema. So we have this lovely little chart here, which is from O'Sullivan, which talks about the different characteristics of sputum and what diseases they're associated with, and even specifically down to what specific organism is causing your pneumonia, which, I mean, that's pretty important. That's some pretty important stuff. And, I had 3 slides on sputum, so, that's probably pretty important. Crazy, right? You're going to assess the patient's breathing patterns, and we're going to practice doing this in lab. You're going to assess the rate, regularity, and location of ventilation at rest and with activity. So abnormal patterns are dyspnea, difficult or labored breathing, tachypnea, which is a breathing rate of more than 20 breaths per minute. Hyperventilation is abnormally prolonged and rapid breathing resulting in decreased carbon dioxide levels. And orthopnea is shortness of breath or difficulty breathing when lying supine. Okay, so those are the abnormal patterns that we're going to be looking for, but we're also looking at just their normal breathing. Breath sounds are assessed using a stethoscope, and it's used to identify congested lung areas for treatment and to reassess for efficacy of treatment. So if we're doing postural drainage or percussion or vibration, we want to listen to breath sounds before and after to see, are we clearing the lungs? And so these are the places where you should listen. And it's abnormal if you hear an absent or diminished breath sounds over a portion of the lungs, and that indicates an obstruction of airways or atelectasis. It's not good. Extra or adventitious breath sounds are characterized as crackles or wheezes. So when we're auscultating with a stethoscope, that's what we're listening for. And so basically, if you're going to do percussion or vibration on someone, you want to listen before, percuss and vibrate, and then listen after. And hopefully you'll hear improved breath sounds. So we'll practice that. Palpation, we're going to palpate for symmetry of pulmonary wall expansion. You should feel a vibration when the patient speaks, because you'll feel the air going in and out. So we're going to palpate different areas and see what we feel. So the techniques that were, besides the assessment, that we're going to do are postural drainage, percussion, vibration, shaking, and not like shaking them so hard that their teeth rattle, but I'll demonstrate. Breathing exercises, assisted cough, and pulmonary mobilization exercises. So this diagram shows the areas where you're going to do percussion. And you do percussion with a cupped hand. So this is the hand position, and it actually feels kind of good. And for the person who is experiencing chest congestion, it feels really good afterwards, so because they can breathe better. Of course, with manual techniques, you don't want to you want to use caution with things like fractured ribs, flail chest, osteoporosis. People are fragile. Evaluated coagulation studies, you don't want to break off blood clots and send them around the body. Or decrease platelet counts because you don't want to increase the chance of internal bleeding. On box 12.4 in the chapter, there are concerns of postural drainage. So there's certain things, certain positions you don't want to get people in, depending. So take a look at that box 12.4 and look at those concerns of postural drainage. We're going to have a whole list of things that we're practicing in lab, and it's fun. I've really only 3 times been in a situation where there wasn't a respiratory therapist doing these, and I had to do it. One was a person with pneumonia. One was after a lung transplant, and one was a person with basically increased mucus in their airways from probably from asthma, even though it wasn't specified that. And two of these were in a skilled nursing facility, and one was in an acute care hospital. So those are the settings you'll probably be doing it. Possibly home health. I don't know about that, but it's not something that you do all the time. So for postural drainage, really we put people in particular positions to aid in the drainage of secretions. So we want to position the segment of the lung with respect to gravity so they can cough and you can suction their secretions so they can get it out of there. And with percussion, we're clapping or cupping in specific areas to loosen secretions. And with vibration, when the person exhales, you vibrate the area to move secretions to the larger airways. So you wait till they're at the peak of inhalation, and then you vibrate in the same direction that the pulmonary system is moving air. And there's some really good videos and demonstrations on PhysioU if you want to take a look at those for percussion, vibration, and shaking. Shaking is while they're exhaling, you kind of you do a little compression on their ribs. So you initiate it at the peak of inhalation, and it's a more forceful way of moving secretions, more forceful than vibration. So obviously there are some precautions with that. And so vibration and shaking are always done on exhalation. For breathing exercises, we're doing these to improve ventilation and retrain effective breathing patterns. So diaphragmatic breathing, segmental breathing, pursed-lipped breathing. These I do all the time in the clinic. Outpatient, inpatient, doesn't matter. You're always teaching breathing techniques. Assisted cough is to aid in a productive cough and stimulate a stronger, more comfortable cough. So people who have weakened muscles for whatever reason might need an assisted cough. Spinal cord injured patients often need an assisted cough because they're your accessory breathing muscles, especially your accessory muscle of expiration, work a lot when you're coughing or sneezing. And if those muscles are not innervated because of a spinal cord injury, you might need help with an assisted cough. And chest mobilization exercises to help maintain or improve pulmonary wall, trunk, or shoulder mobility when it affects respiration or posture. So there are also some lovely videos on PhysioU with these techniques, and we will practice them in the lab. So if you want to take a look at the videos in PhysioU before lab, and lab will not be until the pulmonary lab will not be this coming week. It'll be a couple weeks later because we rearranged the schedule a little bit. So we'll do lecture one day and lab another. That gives you a chance in between the lecture and lab to look at those PhysioU modules and come into the lab feeling a little more confident. So for breathing exercises, forced expiration causes increased turbulence in the airways. And prolonged expiration sometimes causes you to gasp for the next breath. And we don't usually want people to do that. When you're volitionally changing your breathing, you're using accessory muscles and your upper pulmonary area to initiate inspiration. So you want to practice deep breathing only 3 to 4 cycles to avoid hyperventilation. So you'll have people, so when you're instructing people in breathing techniques, you have them do 3 or 4 cycles and then relax and not try to change their breath because we don't want them to hyperventilate.